Let's start off here, Chapter 9 on lifespan development, kind of jumping around a little again. As prior to starting your riding clinical, we think it's important that certainly we have an understanding of developmentally where a person should be based on their age and where they are in their life. That may help you with your assessment techniques as well as what to expect and not expect. So as we move into this Chapter 9 on lifespan development, having a little trouble advancing it. There we go. The learning objectives for this particular chapter, we're going to describe body system developmental milestones, looking at from birth to certainly the geriatric patient, some developmental things that occur, vital signs of infants, toddlers, preschoolers, school-age children, adolescents, early adults, middle and late adults, because vital signs do change from birth till when we get older. And we're going to distinguish some unique psychosocial characteristics of infants, toddlers and preschools, school-age children, adolescents, early adults, middle adults, and late adults as well. We're going to explain some of the psychosocial development of children, adolescents, that result from parenting styles and their involvement with siblings and peer relationships, and environmental factors as well. And we're going to explain the physiologic characteristics and the emotional challenges faced when treating older adults. Now, infants, the American Heart Association defines an infant as birth to 1. There are other terms used to describe those developmental periods. A newly born infant is one that's in the first few hours after birth. A neonate is considered a newly born until 1 month old. And then an infant is from 1 month old to 12 months old. Now, vital signs in infants, we know their heart rates beat a lot faster than ours do, and that can kind of be tricky when we're looking at these heart rates of 180 in an infant. While that may be normal for them, an adult patient, certainly that would be a reason for us to have a concern. Within the first 30 minutes of life, heart rates have a tendency to drop down below that 160, and at age 1 they're somewhere around 120 beats per minute. Their respiratory rates are faster than ours as well initially, and they drop to about 30 to 40 breaths within the first few minutes after birth, and that are about 20 to 30 breaths per minute at age 1. And the reason for the increase in heart rate and the increase in respiratory rate in infants is their high metabolic demand. Blood pressures are much lower, and they're also very difficult to obtain in children if we don't have the appropriately sized equipment. A blood pressure of at least 70 is acceptable after birth, and at least greater than 90 by age 1. The American Heart Association looks at children 1 on up as having a systolic pressure of at least 90 plus 2 times their age. Body temperatures, there's such a wide fluctuation of what the temperature could be based on clothing. Infants have a very large body surface area compared to their overall weight. And as a result of their large body surface area and their high metabolic demand, they generate lots of heat and they dissipate lots of heat faster than we do, and it's very easy for them to become cold. Their weight at birth, somewhere between 7 and 8 pounds, is considered a normal birth rate, and they should gain about 30 grams per day within the first months. They should double their birth weight by 4 to 6 months, and tripling their birth weight by 9 to 12 months. Now, as we look at body and organ systems of infants, the first year development, infants are just learning to coordinate their motor skills, the movement of their arms and legs. and repeated motor actions help them build physical strength and increase their motor coordination. So getting them, to move those arms, move those legs, grasp and hold things, lift things, those sort of things, do help them develop the strength in their muscles as well as increase their motor coordination. When we look at their cardiovascular system, with a newborn, particularly in the first, few hours after birth, we have to consider a change in fetal circulation. In the womb, the lungs are not being used, so there's no reason to pump blood to the lungs in the womb. But as soon as the baby is born, then some structural changes have to occur in the heart that now allows the heart to pump blood to the lungs in order to receive oxygen. The fetal circulatory structures that we should be familiar with include the ductus arteriosus, and this connects the left pulmonary artery to the aorta, and it bypasses the lungs in the womb. Now this ductus arteriosus, within 24 hours after birth, should completely close, and when it doesn't, it may require surgical closure later. The ductus venosus connects the left umbilical vein with the inferior vena cava, allowing oxygenated blood to bypass the liver. Now that ductus venosus closes in about 15 to 20 days after birth. The foramen ovale is a small hole in the atrial septum that allows blood to bypass the ventricles. Blood just passes from one atrium to the other. There's no need for the ventricles to be pumping blood to the lungs, the right ventricle to be pumping blood to the lungs when the lungs aren't being used at all in the womb. So that foramen ovale, that small hole in the atrial septum, closes at birth within the first breath. And if it doesn't occur, we'll talk later in our discussion on infants and neonates, what has to happen at that point. When we look at the respiratory system of infants, their passages are extremely small. They're softer, they're more flexible, they're easily obstructed. It doesn't take much mucus, doesn't take much blood, much soft tissue swelling to completely obstruct their airways. And also we have to keep in mind that their tongue is extremely large in relationship to their mouth. And when you lie them flat, or if they're unconscious and lying flat, the obstruction of the airway by the tongue is very common. The other thing to keep in mind is that when opening the airway of an infant or a child, if we hyperextend their head, much like we do an adult, we can obstruct their airway. The correct placement when you lie a child supine might require you to either put some padding under their head or some padding under their shoulders in order to get the tragus, that little earlobe, pointing directly at the shoulder. If we hyperextend their head, the tragus points up above the shoulder, and if we don't pad them and their large head puts them in a flexed position, then the tragus points down. And we'll demonstrate that in lab. The nasal passages are soft and narrow, just like the other airways. And infants are obligate nose breathers. They've not developed their intercostal muscles. They breathe primarily with their diaphragm, and they breathe primarily through their nose. And so any swelling of the upper airway, whether it's soft tissue swelling or obstruction from fluids like snot or blood, is extremely significant in infants. When we look at the respiratory system of infants, their chest wall is thin, their rib cage is soft, it's very pliant, and the diaphragm their diaphragm is flat. Our diaphragm is domed, and our intercostals are strong, so when our diaphragm flattens and our intercostals contract, that causes a billows effect where our chest rises and air rushes inside our chest. But with infants, when they work hard to breathe, because their diaphragm is flat, when they flatten that diaphragm, it pulls the chest down, and they don't move air as well. So we call that seesaw respirations, and when you see that in children, as we'll cover later in class as well, seesaw respirations is an indication of poor breathing. Their lungs contain fewer alveoli, so there are fewer alveoli available to play in gas exchange. Because they have such small tidal volumes, it's very common for a provider, when assisting ventilations on an infant or a child, to give them too much tidal volume, and as a result cause barotrauma to the lungs. Their higher oxygen demands can lead to a really rapid increase in their respiratory rate, particularly when they get into trouble with shock and those conditions where perfusion is inadequate. They already have higher than or faster respiratory rates than we do, but if their respiratory rates increase above that, it's a lot of work. And work is going to generate heat, and heat is going to increase the body temperature. And also we have to keep in mind that every time anybody exhales, that along with CO2, they're getting rid of H2O, which is water. So they're getting rid of moisture when they exhale. And the faster they breathe, the more moisture they're getting rid of, and can actually become dehydrated from rapid breathing. When we look at their immune system, it's not very robust, and as a result of not being exposed to different proteins and their body developing antibodies, they're susceptible to infections, and particularly infections by unusual organisms. They do have some antibodies provided by them to them through the mother. And certainly if the mother breastfeeds, they continue to receive some of those antibodies in the breast milk. When we look at the kidneys of infants, kidneys in infants are unable to concentrate urine, and as a result, they have more urine output. And that certainly can lead to dehydration if we don't keep them hydrated. When we look at their brain is near adult size. When in an infant. If you look at an infant's head as a general rule, their heads are huge and they just kind of grow into them. But their brain is near adult size, so brain tissue doesn't grow much over time. All the neurons are present, but they're immature. Areas in the brain mature as the infant gets older. As an example, the ability to reason doesn't fully develop until you're about 21 years of age. So, reasoning a 3-year-old, expecting a 3-year-old to reason about a particular situation or to critically think that this action is going to have a consequence is just not going to happen. All the infant reflexes are present at birth, and we'll talk about a couple of them that you can evaluate. With infants, one of the reflexes that is present is the startle response. When an infant feels startled, they'll have what's called the moral response, where their arms will fling out, their legs will pull up, their fingers will fan out, and if you look at that YouTube link there, you can go to that YouTube link and see that, or just type in moral response on YouTube and you can watch multiple videos demonstrating that reflex. Some other reflexes that you should see in infants include the palmar grasp, and that usually disappears after 3 to 4 months of age. So the palmar grasp includes if you lie your finger in the hand of an infant, it will grasp your finger, and it's just a reflex. It's a motor reflex. It really isn't any sort of indication of mentation, but just a motor reflex. Stepping and walking reflex. If you take a baby and you put them flat on their feet and hold them and support them up, they'll lift and pick their feet up, one and then the other. Again, it's not anything they're um, thinking. It is strictly a reflex that disappears at 2 months. And then the Babinski reflex, the positive Babinski, is when you stroke the bottom of the feet of an infant, their toes curl and fan out and their big toe points up. And that'd be normal. We'd expect to see that in an intact brainstem. We can also look at the fontanelles of an infant to determine their hydration status and problems associated with fluid retention. If you look at this diagram, we have posterior fontanelles up front, and we have the posterior means back. We have the posterior fontanelles in the back, and they're up front, which is really visible in the bottom picture of the infant. We have the anterior fontanelle. And the fontanelles are there because the bones, the 4 bones that make up the skull, the frontal bones, the temporal bones, the parietal bones, and the occipital bones, haven't fused together yet, often referred to as soft spots. We can look at those, and if they're bulging, if the fontanelles are bulging, we see that when infants cry forcefully, causing their intracranial pressure to rise. We see that if there is retention of fluid in the head. We see that if they're overhydrated, those sort of things. Meningitis and inflammation in the skull, excess fluid, that sort of stuff. If their fontanelles are depressed, that's a good indication certainly of dehydration. When we look at the nervous system of infants, their sleep needs vary, but they usually get between 16 and 18 hours a day. And at about 2 to 4 months, that drops down to 14 to 16 hours a day is normal, unless, of course, you're dealing with a really colicky infant or something like that, where sleep is not something they get a lot of. We look at their musculoskeletal system. Of course, their bones are soft and pliable, and don't easily break. That's why when assessing infants and young children with broken bones, we can't rule out the cause being physical abuse. But bones grow in length at the epiphyseal plate, and bone growth is influenced by hormones, thyroid hormones, which regulate calcium, and then genetic factors, and then the general health and nutrition of the infant, all attributes to growth both. Muscles continue to grow from birth until adulthood, and the more they're used, like any muscle, the more bulky and stronger they become. Teeth begin to show up at about 5 to 7 months, and you all know they get their first set of baby teeth, and then those go away, and their adult teeth come in, usually when they're 7 or 8. Psychosocial development. When we think about psychosocial development in infants, reciprocal socialization is important. In other words, bonding and that being reciprocal. You loving them loving you back. Scaffolding begins at infancy as well, and that's where a caregiver teaches an infant to do something. That helps create connections with the caregiver. If you can teach an infant to patty cake, or teach an infant to patty cake's the one that just comes to my mind. That's a form of scaffolding. And because they can't talk, crying is their only form of communication, and they might have a different type of cry depending upon what the problem is. Infants will cry if they're sick, they'll cry if they're wet, and they'll cry if they're hungry. And some cries may have different intensities than others. As far as separation, infants will suffer separation anxiety. That's when they cry when separated from a caregiver. And they do this because, certainly they they protest. They don't want to be away from their caregiver. They feel despaired, not certain what's going to happen to them when they're taken away from their caregiver, and they again don't have that attachment with their caregiver. It's often you can make the separation easier if you give them a familiar object to take with them, like a teddy bear or a blanket or a binky or those things. Now, as far as emergency care implications go with infants, you want to observe the infant before actually touching them, and you can do this from across the room. We call that the pediatric assessment triangle. There's a variety of other terms for it, but we'll talk about that certainly in our lectures. But you can observe the infant, their appearance, sick not sick, work of breathing, and circulation to get an idea of whether they have a respiratory or a circulatory problem or a combination of both before you even lay hands on them. You can also tell the amount of distress that they're in as well. An infant that's sitting in its mother's lap crying at the top of its lungs, I'm less concerned about that infant than I am the infant that's lying blissfully in the caregiver's lap. It's certainly okay to keep the infant in the caregiver's lap during your exam so that they don't suffer that separation anxiety. Handle them gently, support their head and neck because they don't have the ability to do that. Certainly don't shake or jiggle the infant. I don't know why one would ever do that, but don't. And then keep the caregiver in sight if possible. Again, this helps decrease separation anxiety if the infant can always see their caregiver. Return the infant to the caregiver as soon as possible. We want to do the least invasive parts of our exam first. If we're talking about getting a blood pressure where you're squeezing the arm, and that's not, I'm not a fan of obtaining blood pressures in infants. To be honest, I certainly know that we need to determine whether or not their circulation is good or not, and we can do that by assessing the differences between their central and peripheral pulses. But that's invasive. You got to remove their clothing. You got to press and palpate. So do the least invasive exam first. Keep them warm. Remember that when you unbundle an infant, because of their large body ratio, their body surface area to their mass, they have a tendency to dissipate lots of heat quickly. Speak softly, smile, touch, rock, hold, cuddle. Do those things that infants find comforting. Go from the toe to the head. Starting right at the head certainly may cause the infant to cry and panic, and then the rest of your exam is going to be very difficult if the caregiver can't calm them down. And avoid physiologic stress, loud noises, claps, those sort of things. Now let's take a look at toddlers and preschoolers. Their vital signs, 80 to 120 beats a minute for toddlers, 80 to 100 for preschoolers. Their respiratory rates are still up there around 20 or 30. Blood pressures are the same. They're going to be 70 plus 2 times their age as a minimum, where you're looking at 90 plus 2 times their age as a normal systolic, and then the diastolic is 2/3 of that. Temperatures are going to fluctuate anywhere between 96.8 and 99.6. Their cardiovascular system begins to grow in strength, begins to function. In other words, their heart and their blood vessels begin to work normally. Their respiratory system continues to develop. They gain those additional alveoli. Their intercostal muscles become stronger. Their diaphragm starts to dome. Their chest becomes less flexible, less reliant on the diaphragm because their intercostals get stronger. The ribs in the sternum are pliable, so they're more resistant to fractures. So what happens in that particular case, because their bones are pliable, their ribs and their sternum, is that they can receive a significant blow. That force can be transmitted to the organs below, and they can have significant pulmonary contusions and perhaps lacerated liver, lacerated spleen, and have no evidence of fracture. Their renal system, at age 2, their kidneys are well developed by then. They're able to concentrate urine. They start to gain control of their bladder and bowel functions. They start to know when they have to go to the bathroom and how to control that, and start to work on potty training, those sort of things. Their immune system, passive immunity, no longer protects them. So the immunity that they acquired from their mother as a toddler or preschooler no longer protects them. And they have to, develop their own antibodies and their own immunities to the proteins that cause us to have these reactions that form antibodies. And one of the theories as to why there are so many peanut allergies in children today is that we've not allowed those children, once their passive immunity wears off, to get dirty, to experience and be in places where they're going to pick up these different things and develop antibodies. They have minor respiratory and GI infections at that age. They are given vaccinations for some of the more life-threatening ones at that age. Their brain function grows faster than other parts of their body as a toddler and a preschooler. At age 2, their brain weighs 90% of what an adult brain does. They have great gains in motor skills, coordination. They start to understand written symbols, colors, can tie their shoe. Their vision completes development as well. Their muscle mass begins to add. Their bone density increases. Their arms and legs lengthen. They start to lose some of that baby fat. They should be walking between 14 and 25 months of age. They may start earlier, and all their primary teeth, their baby teeth, should be erupted and out by age 3. When you look at psychosocial development for toddlers, they have a self-awareness of themselves. They start to develop self-confidence, self-control. They're in the age of no, the terrible twos. They hear no a lot. No, no. So it's often referred to as an age of negativism. And we got to be careful with that. Certainly, we don't want them to harm themselves and those sort of things. And but constant no can have a psychosocial effect later in life. Preschoolers begin to start asserting their independence. They start playing with other children. They are in a period of magical thinking. They can fly just because of things they've seen on TV. They have hero worship starts at that age as well. And they're eager to be given responsibilities. They want to help mom and dad around the house, that sort of thing. By preschool age, their personality pretty much is developed and will be with them most of their life. It's something that's very difficult to change. Toddlers develop, again, that growing self-awareness, self-control, and parenting styles are going to influence that development. Now, if you're an authoritarian parent, where you're very restrictive, you don't allow these preschoolers and toddlers to do anything, they're constantly in that no age, the age of negativism, they're constantly being punished, and they're allowed little verbal exchange with you. They're not allowed to tell you why they did it, why they feel the way they are. They're not allowed to cry. They're not allowed to do those things. Those children go on to develop low self-esteem and become socially incompetent. Authoritative parenting encourages independence but does set limits. And an authoritative parent, these children go on to be responsible, self-reliant, assertive, permissive, indifferent parenting. That's when a parent is essentially uninvolved. They have little control over what the preschooler does. It's like they don't care. Those children go on to become independent because they've had to. They've had nobody to give them guidance and direction. But they also become moody and have low social skills. The passive indulgent parenting skill. These parents are a little more involved, but they don't set any limits. They're involved from the standpoint of they're available, but they don't set any limits. The kids pretty much can do what they want. Those children go on to develop little self-control, low social skills, and immaturity. Now, it's normal for sibling rivalry to occur in families with multiple children. It's a natural jealousy towards a brother or a sister. And if you deal with it in a productive, non-aggressive manner, it'll help the child with critical skills in learning to do things like compromise, to negotiate, and to value other people's views. Peer relationships begin to develop, at 2 to 3 years old. They start to develop basic relationships with other children, play dates, those sort of things. They begin to share, some better than others, take turns, that sort of stuff. Those things help, these peer relationships help them develop problem-solving skills, interpersonal relationship, and develop friendship bonds at an early age. Now, divorce, which certainly occurs in our society, affects children really dependent upon their age. Social cognitive development may be affected. Relationship with their parents may be affected. Children may develop behavioral problems as a result of the divorce. And these result, in some children, they believe they're the cause of the breakup of the family, and they may become depressed, they may become withdrawn, and certainly fear of being abandoned. If it's believed that one parent or the other abandoned the family, what's to say the other one isn't going to abandon them as well? Television violence, there's a lot of discussion about what kids watch on TV, and does it really impact how they act in society. I think the evidence isn't strong. Violence may affect their behavior, so if they watch a lot of video games with violent themes, if they watch a lot of TV with violent themes, it may affect their behavior. I don't know that they're 100% sure on that. But what they do know is certainly because of the magical age that children are in as toddlers and preschoolers, the magical thinking, that cartoons really have a profound effect on children in the 3 to 5 years of age as to what they do and how they act and those sort of things. And I'm sure every one of you recognize Underdog and Casper and Mr. Magoo. Emergency care implications in treating toddlers and preschoolers. When you're examining a toddler, you're going to have to gain some trust, and you have to encourage the child to trust you. And ways that you can do that certainly is, talk to the caregiver. Let's say you're going to listen to lung sounds. You can take your stethoscope and you can say that it's not going to hurt you, and you can place the stethoscope on the caregiver, and you place it on yourself so they can see that nothing's going to happen, and then that will help gain the child's trust. In also gaining the child's trust, you shouldn't lie to them. I mean, if something's going to hurt, you need to tell them it's going to hurt. And you need to tell them, it's probably not a good thing to say, well, this is going to be like a little bee sting. Well, if they've never been stung by a bee, they have no idea what you're talking about. Try not to separate the child or the caregiver. Find out the child's name and use it. Smile, speak calmly in a quiet tone. And if you can, allow them to participate in the assessment as well as the decision. But you may have to set limits. Certainly if you need to give them an injection and they say no, you're not gonna. Well, you've got to come to a compromise there. Respect their modesty. Allow again them to hold the stethoscope, the blood pressure cuff, that sort of stuff. Explain that the illness and the injury is not the fault of the child, because they don't know why they're sick, and oftentimes or why they're injured. They may think they themselves are the cause, and it's their fault, and that may not sit well with them, and so alleviating that stress is helpful. And reassure the child if the procedure will not hurt as well. Don't show needles and scissors unless it's necessary. Avoid procedures on the dominant hand or arm of the child, because that's the one they're going to be moving and using a lot. If you put an IV in a dominant hand or arm, it's likely to get pulled out Avoid covering the child's face. Involve the caregiver in the treatment when you can. Persistent irritability and inability to console or arouse the patient is a good sign of psychological distress. Caregivers should be able to console the toddler or preschool. And because of their small passages and their large heads, and the fact that everything they get, particularly in that younger toddler age, they either stick up their nose or swallow, foreign body airway obstruction is a higher risk in this group. When examining preschoolers, treat them in an upright position if you can. Explain the procedure. Speak quietly. Allow them to hold the transitional objects as well. Tell the child what happens next. Encourage them to be involved in that. Again, warn them if it's going to hurt. And then offer them choices if at all possible. Respect their modesty. Keep them warm. Allow them to stay with a caregiver. And relieve the child's fear of separation. Let them know that the parent isn't going anywhere and that they're going to go with, and that sort of stuff. And again, foreign body airway obstruction is a risk. Now, school-age children, that's 6 to 12 years old, some developmental milestones in those children is, they start to gain weight. They're not these scraggly, skinny little kids. They start to gain some weight. Their coordination is improved. They start to hit puberty. Their body starts to proportion out more like an adult. They start to engage more in unsupervised activities, so the potential for trauma is higher in this group. They start to develop moral and ethical values based on their environments that they're being brought up in, and their social skills are being refined as well, their ability to play well with others and those sort of things. Vital signs, heart rate's still up there a little bit. Respiratory rate's still a little fast because their metabolic demand is much higher than ours. Their blood pressure starts coming around to what ours might be. Their brain function increases in the frontal lobe, and the frontal lobe, that's where mood and memory and those sort of things occur. Reasoning is in the frontal lobe, so that stuff starts to increase. The gray matter peaks, so the size of their brain has come to adult size in weight and that sort of thing. As their brain matures, that certainly impacts their ability to judgment. It starts to solidify their personality, allows them to start organizing, planning, strategizing. They start understanding those concepts. When we look at the reproductive system in school-age children, we have to consider puberty, and puberty begins in girls somewhere between 8 to 13, and boys between 13 and 15. Now, the American Heart Association defines puberty as the development of breast in girls and the development of underarm hair in boys. At that point, they're considered pubescent. The lymphatic system continues to grow until puberty, and then it slows significantly after that. Some psychosocial development in school-age children, they start to relate more with their peers, like small adults. They start to show signs of self-discipline. Those are really stressful years for kids as well, being accepted by the other kids in the school system. Self-esteem issues are extremely common, particularly if they're the only one in class that has glasses or the only one in class that has red hair. So self-esteem issues start to evolve. And psychosocial development varies tremendously in this age depending upon their own maturity, depending on their life experiences and what sort of stressors that they're undergoing. They develop a sense of what's wrong and what's right. Emergency care in school-age children certainly enlists their cooperation. Introduce yourself, be very friendly, sympathetic, explain the procedures, allow them to see and touch the equipment, explain what's going to happen next, warn them if it's going to hurt, and being honest is extremely important in gaining their trust. When speaking to the caregiver, include the child, respect their modesty, reassure the patient of their body integrity. At this particular age, their injuries are believed to be that they will be scarred for life, and that it's much worse than what it actually is. Address any preoccupation about death when it's appropriate. When we talk about the adolescent, that's 13 to 18 years. And this is where they have a big growth spurt. Their heart, their kidneys, their liver, their spleen reach full size. Girls' growth ends at about 16 years of age, and boys' growth ends at about 18. Girls are secreting progesterone and estrogen, which certainly are hormones necessary for reproduction, and boys are secreting lots of testosterone, which are important for reproduction as well. And here's just a picture visual of the different ages, what we consider an infant, birth to 1, a toddler 1 to 3, a preschooler 3 to 5, school age 6 to 12, an adolescent, early adulthood, middle adulthood, and late adulthood. Vital signs in adolescence, relatively normal to ours, maybe on the top end a little fast with the heart rate because their metabolic demands are still faster. Respiratory rate's a little faster. Blood pressure's, pretty normal, around 100, 120 systolic. Core temp is pretty much stable. And their blood chemistries become equal to adults. As far as psychosocial development, again, an extremely chaotic time for the teenager, young teenager, reaching adulthood. A lot of confusion as they strive to establish their identity, who they are, their autonomy, their intimacy, and their sexuality. All those things become, difficult hurdles for children at this age. As far as cognitive development, they've got an adult body in a child's mind because, as I had mentioned, your ability to fully reason doesn't fully develop until you're 21. Some emergency care implications of treating the adolescent. You talk to them as an adult. They certainly view themselves as adults, particularly as they get a little older. When they get up there around 16, 17, 18, you need to carry on a conversation as if you're talking to another adult. Obtain a history from the patient if possible. Respect their independence. Allow them to be involved in their care. Explain clearly and honestly. Allow time for questions. Involve them with treatment if possible. Respect their modesty. Address their concerns. Again, body integrity is an issue. Is this injury going to leave me severely scarred and deformed? Deal with the patient tactfully yet fairly. Provide discharge instructions. Again, vital signs approach normal adult values at that age. And at that age, certainly consider things like substance abuse and endangerment to self and others. Early adulthood, this is 20 to 40-year-olds. They're in their peak condition that they're going to be in, their peak physical condition during this time in their life. Certainly pregnancies occur. Aging begins towards the later, as they get older from 20. Their heart rate more stable, respiratory rate more stable, blood pressure stable, core temp is stable. All the norms and the averages that we've been taught typically reflect this state in our lives. Psychosocial development is less defined. Intimacy is important. They do have a very clear self-awareness of their environment and who they are and how they fit into that, what their station in life is. The middle adulthood, that's age 41 to 60, high level of functioning in all levels. And then you start hitting your 50s and your things start to gradually degrade. Your body function, your body organ function, deteriorates a certain percentage every year once you hit 50. Psychosocial development is less stressful during this time than in early adulthood because they have more experience in life. If they've obtained a professional status and a financial status that they're comfortable with at this point in their life, they're addressing the need or the fact that when you start hitting a certain age, over the hill, middle-aged, things like mortality become, not that you dote on it, but it certainly is something that you're reminded of, particularly when people your age die of heart attacks and strokes and those sort of things. the less active you are in your 50s and early 60s. Certainly, there's a decline in your muscle mass and that sort of stuff. At that age, you may be assuming care of your patients, in which case, if that's something you didn't want to do, the potential for dependent adult abuse is there, the potential for increased substance abuse is there, and people may often go through a midlife crisis during this period as well, where they shuck their responsibilities and just buy fancy cars and get divorces and date younger people and all these other things to try to stay young. When you're over 60 years of age, that's considered late adulthood. Some people define geriatrics as over 65. And at this point, you may have multiple body systems that are affected. You certainly could have hypertension, diabetes, stroke, cancers, and you get a drastic decline in mental and physical functioning prior to death, and that's called the terminal drop. And this bullet point's kind of misleading, because when a person's over the age of 60, it doesn't mean that they can't learn. In fact, it's been shown that they learn just as good as anybody at that age. It just may take them a little longer, but they still have the ability to function quite well. And physical functioning is a matter of mind at that point. Certainly if you choose not to be physically active, that's your choice at that age. Particularly if your hips are bad or your knees are bad, depending on how your life has led up to that. But you can be just as physically fit in these ages. We've got 100-year-old people running marathons. Cardiovascular system, blood flow decreases, your baroreceptors change, so the ability to regulate blood pressure, blood chemistries, those sort of things. Your heart muscle becomes stiff, your ventricles don't fill as full, so cardiac output drops, and you don't respond to shock as well. The respiratory system, inspiratory and expiratory muscles become weaker. You've got a decrease in upper airway muscle tone, and the oxygen carrying capability of your blood decreases because of a lower production of red cells. As far as your endocrine system goes, your pituitary gland decreases in volume, and that's the master control gland telling all the other glands to secrete their hormones. So often at this age you get a delayed or an insufficient insulin release, and type 2 diabetes can be common. Testosterone declines in men, which certainly leads to low T syndrome, loss of strength and vigor and those sort of things. And then in women, a decrease in estrogen and progesterone as they prepare for menopause. Physical changes in late adulthood, when we look at the gastrointestinal system, decreased cues on hunger, certainly thirst causes dehydration. If they're not hungry and they're not thirsty, they don't eat and drink, and so dehydration is common in that age group. Salivary secretion decreases, so eating some foods is difficult because you don't produce the saliva that you need, and if your dentures don't fit right, or if you've got dental problems with your existing teeth, then you just don't eat as well as you should, and that leads not only to dehydration but poor nutrition. Constipation and bowel elimination can be difficult because peristalsis slows down, so the ability to for food to move through your intestinal tract slows way down. Constipation is common. Impaction can be common unless people take stool softeners and eat plenty of fiber and those sort of things. The renal system, kidney weight decreases. You get a loss of the renal cortex, which decreases the ability to produce urine. Bladder capacity decreases. Your bladder becomes smaller. Your bladder muscles weaken. As a result, as your bladder fills, as your smaller bladder fills, the sense of urgency becomes more common. So what you'll have is frequent urination of small amounts. Prostate enlargement certainly can cause a decrease in urine flow as well. The nervous system, brain weight, the number of functioning neurons start to decrease as we just stop using it as much. It's not that when a person turns 60 that they just quit using everything, but certainly if we go into retirement, and depending on what we do in our retirement age, how active we keep ourselves, the less we use that brain, it atrophies just like any muscle. It's going to shrink, the number of neurons are going to decrease. Short-term memory loss might be common, particularly as we get older. Our sleep-wake cycle is disrupted, so our circadian rhythms are affected. They may not require as much sleep. They may only require 4 hours of sleep a night, but they may nap often during the day. Sensory changes occur. Their ability to feel pressure, pain, differences in temperature diminishes, so they can develop significant pressure sores. They certainly can get burns because they don't know how hot the object is that they're touching. They do develop vision problems. It may require glasses. Hearing loss certainly is common as they get older too. One of the last senses to go, as far as in late adulthood, is the sense of smell. They may start to detach from their social network, particularly as friends are dying and their circle becomes smaller and smaller. They may have their own view about aging and what should be done as part of, some societies put great respect in elder populations. Others don't. They may feel useless. As a result, depression is common in this age group. Despair is common as they consider their mortality more frequently. When your parents, my mother's 80 years old, and I see her at this state in her life, being healthy and having no medical problems other than those associated with being 80. But she's preparing. She's getting rid of things. She's putting names of the children on the back of family heirlooms, and all these sort of things are going on in her world, and it's just not something at our age that we certainly are predisposed about. But when you start reaching the ages of 80, you've exceeded the average for length of life in the United States, and things like depression, despair, thinking of your own mortality have to be more frequent. All right, in summary then, a newborn is the first few hours of life. A neonate is somebody who's less than 28 days old. The typical newborn weighs between 3 and 3.5 kilos, or roughly 7 to 8 pounds, and they should triple their weight by the end of year if they're thriving well. Consider or keep in mind that immediately upon birth there are several circulatory structures that have to close in order for normal circulation to occur to the lungs, so that oxygenation can occur through the lungs, and sometimes that becomes problematic, and we'll address that in a later chapter. The nervous system functions in an infant are primarily reflex and not really thought driven or as a result of mentation. Toddlers are considered 1 to 3 year olds, preschoolers 3 to 5 years old. Toddlers and preschoolers have a rapid growth spurt. They undergo an increase in muscle, bone, and mass. Walking generally occurs by 14 or 15 months, and that our parenting styles certainly have a significant impact on how a child develops into adolescence. School-age children are 6 to 12 years old. Adolescents are 13 to 19 years old, and by then their growth is nearly completed. They've made that transition to adulthood physically. They reach their sexual maturity, certainly men sooner than women, but their brain may not quite be there yet. Early adulthood is 20 to 40 years of age. Body systems peak in their performance. Love relationships occur. Parenting occurs if certainly children are in the picture. Middle adulthood, that's when we go through menopause. We start to develop and see signs and symptoms of aging. Late adulthood, that's over 60. Body systems begin to deteriorate just based on the natural genetics, based on your overall health, and based on your lifestyle. Your nutrition, your exercise, your social involvement, all that affects your body system deterioration. Alright, so that brings us to the end of Chapter 9 on lifespan development. If you have any questions, you certainly can email me, or we'll post a message on the Iowa Western Community College Paramedic Blackboard or web page. I'm showing my sign. We don't have blackboards. We have web page and chat rooms and those sort of things. So with that, I will talk to you soon.